For joining this morning for this webinar, and I look forward to the Q&A that will follow later on this morning. So just in terms of, as Jane said, I'm Dr. Jeff Hanna. I'm a lecturer in clinical cancer nursing, working in a joint clinical academic role with Ulster University and the Southeastern Health and Social Care Trust here in the north of Ireland. Just in terms of the presentation this morning, I'm going to take you through a little bit of my journey into nursing, which I like to often describe as a bit of the scenic route. My current role is balancing a clinical academic post and then the Q&A, which will follow after that. So my background, I completed my bachelor's degree in psychology at Queen's University from 2012 to 2015. Following graduation from that, then I worked as a research assistant then within the School of Psychology for a period of 2 years. I then had reached that point then where I was very keen to wanting to progress then into completion of my own PhD, which was completed at Ulster University from 2017 to 2020, where my PhD looked into the support needs of supporting families when that parent or significant caregiver for children was at end of life with cancer. That was following undertaking a systematic review. There was a large qualitative study conducted then with four sample groups, being parents at end of life, bereaved parents, health and social care professionals, and funeral directors. And across those 79 interviews then, which had been conducted then, there were five peer-reviewed publications which did come out of the work at that point in time. Now, as a result of the PhD, what we did identify and what we were able to draw conclusions out of from this piece of work was trying to understand the landscape and the journey of the support needs of families throughout that last year of life, with key highlights of identifying where best health and social care professionals could support families throughout that end of life trajectory. So, at the time of receiving that poor cancer prognosis, the key aspects of where health and social care professionals could support families was ensuring that families were given that honest information surrounding the poor cancer prognosis. They were provided with that guidance and support on how best to tell the children and giving that advice on how to make those important preparations for the future. The purple line then, which is running through the screen, was very much reflective of how many parents and families had seen their end-of-life trajectory, where there had been these ongoing deteriorations throughout that end-of-life period, and then there became that falling off the cliff stage then throughout those final short weeks and days of life. Now, throughout this trajectory, which varied for many families from periods of weeks till months, there was very much families were living in parallel worlds at that point in time. There was very much this sense that life was going on, routines were being maintained, such as children going to school, parents continuing with work. There was very much making the most of their ordinariness. So if they were doing things such as going to the park for a picnic, there was taking of more pictures and photos and videos at that point in time, with very much, families living in that space of striving to live, being captured through that hope and treatments then that the death would not be so imminent, and also hope from spiritual faith then, which was important for many families. As I've said, then there was this point in time for families where they did come to that falling off the cliff stage, where many families felt that death had actually caught up with them sooner than they had actually anticipated, often feeling they would have a lot longer before death would have been imminent. For many families, there was often an avoidance then of having important conversations with children throughout that end of life period, hence the falling off the cliff then, where there was this rapid searching the internet, support and guidance then from health and social care professionals on how best to tell the children the reality of what was going on. And for many families then, they were feeling ill prepared at this point in time, having reflected that they wish they had had those earlier conversations with the children, and also having made those earlier preparations for life after the ill parent would have sadly died. Now, that's just sort of a quick snapshot then from the PhD study which had been conducted. And at that point in time, what we did do was develop then a guide for professionals, which is 10 top tips for parents and carers with life-limiting illnesses to have conversations with children. And alongside my supervision team, being the late Professor Eilish McCacken and Professor Chair Semple, we worked alongside colleagues at King's College London, being Professor Richard Harding and Dr. Steve Marshall, to develop this resource, which is currently freely available through Marie Curie's resource platform. So moving on then beyond the PhD, then I had then taken up two postdoctoral research posts at the same time. I suppose one of the benefits the pandemic actually did bring to my career at this point in time was the ability to hold down two postdoctoral experiences. One based at the University of Strathclyde in Glasgow, another being at the University of Oxford. And it was very much the sense of without the pandemic and having remote aspects of working, I probably would not have been in the position to hold down these two research positions. The first of all, then the post then which I had held at the Department of Psychiatry in Oxford, I had the opportunity to be still continuing working on aspects of family-centered cancer care, looking into experiences of preparing children for end of life during the COVID-19 pandemic. We also conducted the first national studies then looking into experiences of end of life care through the lens of health and social care professionals and through the lens of bereaved families during the pandemic. And these studies were published in Palliative Medicine. I'd also been involved then in other studies during my 10-month period at the Department of Psychiatry, specifically looking into experiences then of perinatal health services and the experiences of young families of parenting during the COVID-19 pandemic. And the slide on the screen just shows some of the publications that had come out from that work. Then at the School of Social Work and Social Policy, then at the same time at the University of Strathclyde, the research that I've been involved with at this point in time then was looking into the experiences then of those over the age of 60, over the age of 65, and over the age of 70, depending on the study that we were conducting, of experiences of bereavement by suicide in later life, or looking into how suicidal ideation then manifested within an older population. And there's been four published outputs from that work, which is also shown on the screen. I then very much had this mindset then. I was conducting all of this research, being very heavily involved within the cancer space, the bereavement space. And what I very much had the very firm belief if you want to make that difference to practice, it's important to be in practice to be able to influence then those around you, then, particularly then being health and social care professionals, being the key remit of where my research had been focused to influence the delivery then within that person-centered aspect. So I then completed between September 21 and August 23 my master's in professional nursing at Queen's University in Belfast, with that striving aim then of becoming a registered nurse. At the same time then, life was still living very much in the fast lane. I had held a 5-month then postdoctoral research post at Queen's University whilst completing my full-time master's. And then I had then came back then to my roots, as I suppose you could say, to Ulster University and had completed a postdoc research post at that point in time. And I'd also been undertaking then Band 3 healthcare assistant shifts within the Southeastern Health and Social Care Trust. So life was very much busy at that point in time. But just to give you a sense of what I was doing within those posts, at the time of returning back to Ulster University, I was very much wanting to, and what did I had achieved them was working within the family-centered cancer care and very much focusing on education for professionals on how best to support families throughout that end of life period. Alongside Professor Chair Semple, then, one of the first aspects that we had been doing was developing a communication framework for health and social care professionals on the when and how to start important conversations with parents on how to communicate the poor prognosis with the children. The communication framework, which is a 1A4 page, which can be seen on the right-hand side of the screen, is a two-step framework. The first aspect of the framework then uses simple prompts on how to open up those conversations to explore parents' attitudes, beliefs, and readiness about sharing the poor prognosis with the children. And the second step, providing that more concrete guidance on what it is families need to know as they prepare to start this conversation with the children. Then what we had also completed at this point in time then was we worked alongside the Lyric Theatre in Belfast alongside a creative learning educationalist and professional actors to develop short educational video resources being 2 to 3 minutes in duration on how healthcare professionals can have these important conversations with parents in routine practices. The videos take you through that trajectory from the moment a parent receives that poor cancer prognosis until death is more imminent into those final short weeks and days of life. In the development of these videos, what we had done was brought together the 79 transcripts from the interviews that had been conducted and had actually deciphered what was the key elements then to be illustrated within these educational video resources. Of the 7 videos, the first one looks into how healthcare professionals can start that important conversation with parents, ensuring they understand the reality of the poor cancer prognosis. The second video then looks into what does life look like for those parents beyond leaving that consultation room that day. And as healthcare professionals, that's something we often don't see in our practices. And what we wanted to illustrate from that video is what does life look like for those parents beyond leaving that consultation that day. The third video then is the parents back into that sort of consultation room and about starting that important conversation in relation to the children. The fourth video moves into how we can start those conversations about making important preparations for the future. And then the final 3 videos looks into how we can support families as healthcare professionals as death becomes more imminent into those final short weeks and days of life. Video 5 is about providing that honest information that death is approaching and is expected soon within that 2 to 4 week window, and how families can best navigate that period. The sixth video then is glimpses into what family life looks like for those families within that final 2 to 4 week window. And the final video is whenever death is more imminent within that sort of 24, 48-hour period, and how we can support families at that point in time and how children can be involved then within the dying experience. So we had started to build up then a number of resources, and what we had wanted to achieve at this point in time then was delivering then face-to-face educational sessions for health and social care professionals on how best they can support families throughout that end of life period. So what we had done was we developed then a face-to-face educational training program, which was 2 hours in duration. It was guided by the evidence base from these 79 qualitative interviews that had been conducted, the communication framework, which I've shared with yourselves, the educational videos, and we also had a bereaved parent then share her lived experience then, which was very helpful encapsulating them, putting the research and the lived experience collectively together. And the 2 hour sessions then had been facilitated by myself and Professor Cherif Semple. So over the last couple of years, we've probably delivered this training to over 2,000 health and social care professionals across the UK and Ireland. And there is a reference just onto the bottom of this slide then, which is a mixed methods evaluation then of this educational program. We've evaluated the program using Kirkpatrick's model of evaluation, specifically looking into levels 1, 2, and 3, looking into the reactions and looking into the learning that has been applied then from the training. As a result of the mixed methods, what we did do was a quantitative survey pre and post training, and then qualitative interviews then had been conducted with professionals up to 18 months after they had taken part in one of the sessions to explore how they had actually utilized and had embedded the learning from the training then into their clinical practice. We did find a significant difference in scores of self-efficacy within the pre and post, and within those qualitative interviews conducted up to 18 months post-intervention, what we did find then was that healthcare professionals were finding that they had more confidence and were actually taking the initiative to engage in these conversations, which previously they did reflect on that they didn't have or felt they had the knowledge and skills to be able to do so. Of course, then there is also the sustainability of this training. While we've been doing opportunities of being able to facilitate face-to-face, we do recognize then that that is not a sustainable model for moving forward. So over the last 2 years, what we have been doing alongside colleagues at UCD and DCU, funded by the HEA then, was adapting, testing and evaluating the face-to-face training into a standalone e-learning resource. The e-learning resource is 40 minutes within duration and does also include then the short educational videos, the communication framework then, and other activities then embedded within an e-learning resource to promote engagement. That e-learning resource is freely available onto the Palliative Hub, kindly hosted by the All Ireland Institute of Hospice and Palliative Care. And we have three publication outputs from this work then, which are also shown on the screen, reflective of a systematic review which we conducted to identify what other educational interventions had been available and identifying how best we could utilize the learning from those interventions as we develop the e-learning resource. And the other two publications are focused on to the development and the adaptation from the face-to-face to the e-learning using Yardley's person-centered approach, and then an evaluation then of the e-learning resource using a mixed methods approach, also looking into pre-post test surveys and then follow-up interviews 4 to 6 weeks post completion of the e-learning resource. Then, just late towards last year, then we've worked alongside Lisa Strutt, who has been our bereaved parent journeying alongside us over the last couple of years and who had been coming along to the face-to-face roadshows in sharing her lived experience, where we've actually co-authored then a book chapter together in a new book which was published last year, edited by Kerry Jones and Joe Horn, which is Understanding the Grief and Loss Experience of Carers. And what we've done within our book chapter then is integrating the science and the art and the lived experience of the research findings alongside Lisa's own personal experience, taking through the end of life trajectory, being those last 12 months of life, into those first 18 months in the post-bereavement space. And the reference then for that book chapter then can also be seen onto the slide. So following completion then of my master's in professional nursing, I had worked alongside then a couple of months then finishing within the research associate post at Ulster University, also working as a Band 5 registered nurse within the Southeastern Trust. And then 1 year ago, next week then, I've was appointed then as a lecturer in clinical cancer nursing across Ulster University and the Southeastern Trust. So in terms of the joint clinical academic role, it is a 60-40 configuration where I'm 60% being 3 days a week based within Ulster University and 40% being 2 days a week based within the Southeastern Health and Social Care Trust. So just to give you a snapshot then as to what does this look like for the configuration of my job role, my 60% being my 3 days based within the university are focused within a research and a teaching capacity. And just to give you a little bit more of a snapshot as to where is the current direction of the research going that I am involved in, continuing with the family-centered cancer care program of work. As I mentioned, we have evaluated our face-to-face and our e-learning training using Kirkpatrick's model, focused on levels 1, 2, and 3. But we're currently working on to the evaluation of this training with a particular focus on getting to that level 4 being the results and trying to understand the impact of that intervention. So while we've been able to determine what impact the intervention is having through the lens of healthcare professionals, to determine that fourth level, what we are currently aiming to do is explore what impact the intervention is having through the lens of families. So what we're currently working with Foyle Hospice and Marymount Hospice, where we're delivering the training to over 80% of all clinical staff based within each of those clinical areas. We've completed pre and post surveys already within both organisations. And we're a little further ahead with the work with Foyle Hospice, having started there a little earlier. And we've been able to do 3-month follow-up surveys then with health and social care professionals within Foyle Hospice. Preliminary findings of that data, we've identified that while there was an increase in self-efficacy between the pre and post, self-efficacy had actually increased again then at that 3 months completion of the intervention. And having then conducted individual interviews and focus groups then with the clinical staff at Foyle Hospice at that 6th-month trajectory, what we were able to identify and capture then was that actually having then the exposure of going out and having these conversations in practice was ultimately increasing and impacting onto self-efficacy overall. We're now at a 12-month stage then of having completed the intervention with Foyle Hospice, and we're now at the stage of going out then to recruit both parents and children who have experienced care through Foyle Hospice to determine what impact then the provision of family-centred care had onto the family's experience after receiving care through Foyle Hospice. So that's where we're currently at from that line of work, and we're sort of 12 months behind with Marymount Hospice, but we'll be aiming to achieve then the same outcomes from the work through that organization as well. We're also working with the University of Southern Denmark, where our communication framework is now being adapted and culturally tested for appropriateness within a Danish population. We're also hoping to be striving forward towards an impact case study for the Research Excellence Framework at Ulster University for the 2029 REF. And we've just recently received successful funding through the NIHR to continue our work within the family-centred cancer care space to try and understand then how our resources and try to understand then how care is actually being appropriate for those families who are living in deprivation across then the UK. Then another study then, which we are currently involved with then, is within head and neck cancer and suicide ideation. And this is essentially bringing together then collective interest from clinical perspectives as well as research projects that have previously been completed. We've just undertaken a systematic review and meta-analysis exploring the risk factors, challenges, experience, and needs then of those people with head and neck cancer who have either had thoughts of suicide or have actually completed suicide, and that is currently under review. We've also received funding from the Southeastern Health and Social Care Trust to conduct a global study exploring health and social care professionals' experiences and views in caring for people with head and neck cancer who have experienced thoughts of self-harm and suicide. And as you can see from the map on the screen, our qualitative study has progressed with interviews being conducted across 14 cultural contexts at this point in time, and recruitment is still open for that study. We also have an interdisciplinary PhD researcher who's going to be starting with our team in September 2025, where we'll be looking into the use of arts-based interventions then to be able to explore and to imagine the needs of people with head and neck cancer experiencing suicidal ideation, and also looking into interventions then that could be used to support this population who are experiencing thoughts of suicidality. Then within the other 40% configuration within my clinical role, I'm currently based within the Ulster Hospital in Dundonald in an acute surgical unit, where I'm spending between 1 to 2 days, depending on each week, then based within the surgical assessment unit. There is also then the bringing together then of both organizations together, being those joint clinical academic roles. And one of the examples of this then is through some of the teaching then which I have been facilitating and being part of within Ulster University. Opportunities then have been available for colleagues within the Southeastern Health and Social Care Trust to come to the university to avail and to access of that educational curriculum. And there is ongoing work within this space then in supporting colleagues within the trust then who are aiming to pursue research activity at trust level with the support of myself and other colleagues then through the university. So in terms of thinking about the joint clinical academic role, these are novel positions and are not they're not so widely held. In preparation for this webinar, I was thinking to myself, well, what has been the key to the success then in being able to maintain this role? And there's sort of three key aspects then that I feel are particularly important for anybody who's embarking in that clinical academic role or is striving towards that. And the first, though, one of those is that sense of partnership and that real coming together. It's important to be bringing both organizations or whatever the configuration of the job role would be together to review goals, to set targets, then to review progress then that has been achieved, and ensuring that both organizations understand then where the benefits of the partnership is coming in and how that would actually equally benefit them, both organizations. A key to the success is also having that flexibility. So for me, within my configuration, then it's identifying where best I would be able to have those clinical days placed. So while some other individuals with joint clinical academic roles maybe have set days of saying their university Monday, Tuesday, Wednesday, clinical Thursday, Friday, for me, the success is having that greater flexibility of identifying on a monthly basis where my clinical would be best fit that could be arranged around other activities that are taking place. Having those greater opportunities for flexibility does enable greater opportunities to attend other events, or but depending on what is happening at either trust level or clinical level, to ensure those opportunities are available then to attend those. There's also the importance then of managing time and diaries. And that doesn't just think about myself as an individual, but also thinking about the other teams I work with. So I'm mindful of other individuals I work with between trust and through clinical levels. They may have set days within their role. So it's important that whenever I'm identifying where I would have my clinical days and university days, that I am enabling those opportunities for that shared collaborative working together. But also for myself, it's also identifying what is going to be manageable within an appropriate space and time. The benefit of having then the 60% at a university level and a 40% academic or 40% clinical is the opportunity of thinking, what's happening at this point in time and where can you reduce and spread work at a point in time that will actually enable more productive work to take place. So, for example, if I'm working with students at the university level on a Monday and on a Wednesday of a particular week, with the desire of having students being able to work on certain aspects or other researchers who are part of research projects to complete work while I'm then at clinical point in time, that gives them the opportunity to be working on that. That does mean then that the next day I come back with to the university setting, it's more productive because there has been that time and scope and space away from what has been completed at that point in time. There's also then the importance then of self-care, and it's about taking ownership and control over what it is you're able to do. So first of all, thinking about that sense of planning workloads, it's always that sense of thinking ahead of what's going to be coming down the track within particular aspects of activities within each of the job roles. So for example, at the moment for myself, I'm quite heavily involved with the teaching module at the university. So I've had to think ahead of thinking, well, where am I going to allocate time for marking and where will that fit around then other activities that are taking place, such as research, as well as my clinical capacity as well. There is that sense then of setting realistic targets, and sometimes that can be quite challenging, whether you're in that full-time academic position or whether you're in that full-time clinical position. But thinking from that academic perspective of applying for research grants, you don't know what's going to be successful and what's not going to be successful. So you do find, you have periods where you might apply for maybe multiple grants, and maybe, you have that optimistic thinking perhaps they will be successful, maybe they won't be successful, but you're always having that contingency plan thinking, okay, if these were all successful, would you be able to manage them? If they're not going to be successful, what's going to be your backup plan, I suppose, at that point in time to ensure the continuation of the role to continue? In terms also of thinking about self-care, sometimes it's important to be thinking about where does downtime come into this? And I suppose reflecting from my own personal experience, sometimes that can be found easier within one sense as opposed to another. So my experience is within a clinical sense, sometimes it can be easier to have that downtime because if you have that out of office on, if you're out of that clinical environment, the clinical work is still going, but other colleagues within the team are very much picking up that work. And sometimes it can be easier then you come back to that at that point in time. But when you think about the university work, it's the exact same. You have colleagues who may be able to continue with work, but you're always mindful of emails that may come in that do require attention. You've deadlines for projects, you've also teaching, you've marking. So it's sometimes thinking, where do you sort of be kind to yourself and identify where does leave best come into the role. Within my joint clinical academic configuration, I'm full-time within that role. I manage my annual leave 100% from the trust level. which makes it easier then in the sense of having that transparency then of whenever I'm not in the clinical, it's clear, and then I can communicate the same back then to the university. Whilst then I'm full-time clinical, full-time within my job role, that means I am still clinical over the Christmas period, but I'm mindful that the university is closed at that period, so that then increases time clinically over that period, unless I take annual leave at that point in time. But there's also that sense of remaining, not guilty about the sense of from my own personal experience, I took annual leave in January whenever university colleagues were back. But I also had to be mindful of the sense of I was still full-time clinical over the Christmas period. So there's just that sense of, it's about balancing the roles, but also having that clear, open, and honest communication across both organizations at the same time. And the third thing then, which kind of encapsulates then all of this collectively together, is saying yes to the right opportunities. And as academics, you often, you don't want that opportunity of saying no to something because you don't want that to rule you out of that opportunity at another time point. But it's also important to ensure, are you saying yes to the opportunities that are going to help to promote and to sustain your career, and also to ensure that you can actually be able to deliver the work, as opposed to thinking of that sense of, are you setting yourself up for a failure of taking on too much that you're not able to deliver it to the quality that you wish to do so? So thank you for taking the opportunity to attend this webinar this morning. And I would like to invite any questions anybody does have in relation to anything I have discussed this morning.